to next speaker, Professor Guel, is my dear friend and an eminent neurosurgeon and spine surgeon. Please say go ahead. Thank you. Thank you, Professor.
Okay, Dr. Samay, my dear friend, and it is my great pleasure and a big honor to give you this presentation, and you have given the title Revolution. So I am going to present a revolution in spine surgery, not revolution in technique, not revolution in instrumentation, but revolution in philosophy, revolution in concept. And I introduce to you a new concept. And I look beyond decompression. Whenever any spine surgeon is talking, the main issue remains compression is the problem and decompression is the treatment. I am introducing a new concept, a revolution, that compression is never the issue and decompression is never the solution. So looks quite dramatic, looks quite dangerous, but let me give you this presentation, and I hope I can convince at least some of you. So the concept is, for majority of, you can hear me, Samay, right?
Yes.
Okay. The concept
Yes, but
is,
there is some echo.
some echo is there, John?
Yeah, okay, hold on.
Okay. So my concept is, for a number of issues, instability is the problem and stabilization is the solution. It is not decompression of compressed structure that is the issue at all. So that is the question. So the main issue in the human body is that we have a standing human position, like no other animal in the universe. Our muscles of the back are strained or stressed throughout our life. Like in a bird, the muscles are in the wings and in the shoulders. In a four-legged animals, it is on both the basis of both legs. There is the problem is, if at all there can be a problem, it can be in the legs, in the wings. But in the human body, it is the muscles of the spine or the back which can be a problem. So all the muscles of the human body are located in the back. There is hardly any muscle in the front of the spine because of the extensor dominance of the human body and the standing position. So what happens in the human body because of the standing position throughout life, there is a telescoping of the spine or vertical facetal instability, which leads to degeneration of the spine. So that is my concept, that standing position leads to telescoping of the spinal segments, and that leads to vertical spinal instability that cannot be seen by radiology. MRI will not show you that instability. CT scan will not show you because the instability is vertical and it is facetal. So these are the two things which I will like to discuss. So as I mentioned to you, the entire human spine is posterior or extensor prominent or predominant. Anteriorly in front of the spine, there is hardly any muscle. There are only longus colli, which are very thin and flimsy muscles. So most of the activity or the entire activity of the human spine is based on the posterior muscles, and they are focused on the facets. The most mobile segment of the spine is craniovertible junction or atlantoaxial joint.
Mặc quần áo tay dài, nhớ chưa? Rồi. Phải mặc quần áo tay dài.
John, there is some nice voice coming from behind. Is that some problem? John?
It's okay, sir. It's okay.
Okay, okay. So the whole body, the muscles are located in the back, and they act on the facets. And the most mobile segment of the human spine is atlantoaxial joint. The other concept which I want to mention before you is, more the mobility, more the possibility of instability. More mobile is the region of the spine, more potential of instability. So atlantoaxial joint is potentially the most unstable joint of the body. I have no hesitation to say that atlantoaxial instability is the most common form of instability in the entire spine. I have no hesitation to say that the atlantoaxial instability is the most under-recognized and under-treated clinical entity by spine surgeons. The facets are the issue. Is not issue. Disc is divine. Disc can never be a problem. That is another very major issue which I will discuss. That disc is never a problem. Don't do discoidectomy unnecessarily. Instability is the issue, and instability is focused at the facets. So before I go to subaxial spine, I want to discuss about craniovertebral junction. Many of you may not know that about 25 years ago, basilar invagination was treated as a fixed anomaly. Odontoid process going up, we classified into two groups, odontoid process going up and tonsil coming down. These were the two groups. And in 1998, I described myself that this group needs transoral decompression and this group needs foramen magnum decompression. So that was my understanding in 1998, that instability is not the issue. Instability was not considered a problem. Compression was considered a problem in 1998. In 2004, we said that group A, the odontoid, when it goes up, it is an unstable spine and it does not need decompression. It needs craniovertebral junction realignment. So we said that decompression is not required for group A. In 2004, we said that group B requires decompression for Chiari malformation and for basilar invagination. So we changed for group A. And since the year 2000, we have got several hundred cases where we have not done any form of decompression. We have done craniovertebral junction realignment and more than realignment, stabilization. So instability is the problem and stabilization is the treatment. Decompression is not the treatment. That is what we said. This was the first case in the year 2000 where we did not do any transoral decompression. We did open the joint, distract the facets, and realign the craniovertebral junction. There is no decompression. So we have got several hundred cases with this kind of issue where we have not done any decompression. And I am absolutely convinced that for basilar invagination, decompression is a negative form of treatment. Instability is the issue. Do not remove any bone. You remove any bone, you increase the instability. So instability can be increased by your decompression. Do not do any decompression. Rotatory dislocation was considered to be a fixed kind of anomaly, and before this article which we wrote, the whole world was doing decompressions for this kind of anomaly. We introduced the concept that you open the joint, realign the craniovertebral junction, and you can give a beautiful face and beautiful smile and beautiful power in the lips. There is no decompression necessary. Even for this boy, he has lost his wonderful hair, but gained a little bit of a smile and a little bit of straightening of neck. No decompression, stabilization is the treatment. open the joint, manipulate the facet, realign the craniovertebral junction. This concept has completely revolutionized craniovertebral junction surgery for sure. And many people in the world who are focusing their attention on craniovertebral junction know how to do realignment. Many of you may not know of this entity, fixed atlantoaxial instability or fixed atlantoaxial instability. This was a very commonly discussed issue about 25 years ago. So this article of mine, which was published as cover page of Journal of Neurosurgery, we said that there is nothing like fixed atlantoaxial instability. You can reduce the instability by manipulation of the facets. So this is fixed inflection and extension. There is no movement in the odontoid process. Open the joint, realign the craniovertebral junction. Essentially, we said that there is no need for decompression in these cases. These are unstable spine and stabilization is the treatment. So similarly, this is another case where there is, otherwise the whole world was doing transoral decompression and many of the people in the world were doing foramen magnum decompression. No decompression is required in such cases. And this is quite a change in the concept. So the concept is basilar invagination, instability is the problem and stabilization is the treatment. That is the concept. And there is no hesitation to say that we completely demolished transoral surgery from the domain of craniovertebral junction in general and basilar invagination in particular. Standing human position and lumbosacral listhesis we all know. In the year 1999, we said that there is listhesis of C1 over C2, which is due to unstable craniovertebral junction. Basilar invagination is instability and basilar invagination is listhesis of C1 over C2 in 1999. And accordingly, we treat it like this is basilar invagination, Chiari malformation, syringomyelia, basilar invagination. Listhesis is the problem. Realignment is the solution. There is no role for decompression in this operation. Absolutely, it should be clear. Then we introduced an absolutely revolution in spine surgery, in craniovertebral junction surgery. And I want to give you this revolution, which Sameh likes to call revolution in spine surgery. This concept of central or axial atlantoaxial instability, if you read between the lines, central or axial atlantoaxial instability is present in all cases of Chiari malformation, syringomyelia, cervical degeneration, OPLL, Hirayama disease, and I will like to discuss all these things and in relation with instability. So let me show you first type 1 instability, listhesis of C1 over C2. Listhesis of C1 over C2, there is atlantodental interval disturbance. We know this. When only parameter to describe instability in the literature is atlantodental interval disturbance. So there is compression of the cord, there is listhesis. So we said that there is no need for decompression, you do stabilization. Now you see another one. Type 2, facet of C1 is behind facet of C2. There is no atlantodental interval disturbance. There is very severe basilar invagination. I have to tell you that the whole world, even today, will do foramen magnum decompression for this. And I have no hesitation to say that foramen magnum decompression is a negative operation in this situation. Instability is the problem and stabilization is the solution. C1, C2 instability is the issue and C1, C2 stabilization is the solution. So this is type 2. There is no atlantodental interval disturbance. Now I want to talk about type 3. There is no atlantodental interval disturbance, but there is assimilation of atlas, there is Chiari malformation, there is syringomalia. All these are secondary events, and all these indicate atlantoaxial instability. Even when the facets are in alignment, you do atlantoaxial stabilization and you see an absolute magic. Magic in return of syringomalia to normalcy, more than anything else, magic in the clinical condition of the patient. I have no hesitation to say that decompression in this situation will be a negative operation. So basilar invagination and instability there is no question. And all types of basilar invagination, whether it is group A, whether it is group B, atlantoaxial instability is the issue, and atlantoaxial stabilization is the solution. Another thing I want to mention, inclusion of the occipital bone and the subaxial bones in the fixation construct are negative operations and should not be done. So there is no atlantodental interval disturbance. There is facetal type 2 malalignment. I call it axial or central atlantoaxial instability. There is Chiari and syrinx. There is no question in my mind that decompression, which is done all over the world, is a negative operation for Chiari and syrinx. Instability is the issue and stabilization is the solution. You do this. It is not an easy operation. Problem is, if it is not easy, does not mean it is not correct. Atlantoaxial fixation is the solution, and you see the magic in syrinx in 100% of cases, and more than anything else, magic in the clinical condition of the patient. Even when there is no atlantodental interval disturbance, even when there is no facetal malalignment, presence of tonsillar herniation is an indication of an unstable atlantoaxial joint. There is no tight posterior fossa. This entity of tight posterior fossa was introduced by me in 1998. I said in Chiari and basilar invagination, there is tight posterior fossa and decompression is the treatment. Today, I say that decompression is a negative form of treatment. Atlantoaxial stabilization is the treatment. So syringomalia, Chiari malformation, you have, if you want to see the magic, you have to learn this atlantoaxial fixation. Facetal instability may be present or may not be present. All these assimilation of atlas, Chiari formation and tonsillar herniation and syringomalia are all secondary to atlantoaxial instability. So what I'm saying is, when there is chronic atlantoaxial instability, there are many naturally protective maneuvers which God does, and which I will show you what the God does. You see there is syringomalia, tonsillar herniation, only fixation, and you see the magic of syringomalia gone. This is another case. You see how the syringomalia has reduced after surgery. So basilar invagination, Chiari formation. I do not like to call it Chiari malformation. It is a divine intervention. It is a naturally protective phenomenon, this tonsillar herniation. Atlantoaxial instability is the cause, and atlantoaxial stabilization is the treatment. And I have no hesitation to tell my dear friend Sameh that this is a revolution in the treatment of Chiari malformation, in the treatment of basilar invagination, in the treatment of syringomalia, and a treatment of many other problems which I will discuss. So we recently presented our work with 388 cases with remarkable clinical result, remarkable. Syringomalia resolved in remarkable number of cases. I wish you can read this article to know the exact details. So Chiari is not a malformation, it is a formation, it is a nature's airbag. It protects in cases of potential or atlantoaxial instability against damage to the spinal cord. So it is a natural airbag. potential or manifest atlantoaxial instability. So when there is atlantoaxial instability, many things happen. One is Chiari, I have discussed, syringomyelia, I have discussed, cervical fusions happen. And these are all protective responses to instability. They are not abnormal. Bifid formation is a dynamic phenomena. It is not a problem. It indicates when there is bifid, it indicates atlantoaxial instability, even when the dynamic images are not showing instability. You see, there is no instability here. There is no compression here, but there is fusion of multiple segments. There is bifid here. So these are clear indicators of atlantoaxial instability, and you have to. There is no other solution. You cannot do any osteotomies here or decompressions here, which will be negative operation. Atlantoaxial instability is the cause and stabilization is the treatment. We said in this beautiful article that os odontoideum is a natural, is a divine section of the odontoid process. In the presence of atlantoaxial instability, there is no need for any transoral decompression, which will be negative operation. I must tell you, my dear friends, transoral decompression is still done in many parts of the world for os odontoideum. There is no need for occipitoaxial fixation. It is an indicator of atlantoaxial instability. It is an indicator of need for atlantoaxial stabilization. Syringomyelia is not harmful. It is helpful. It is secondary. It is divine intervention in the presence of chronic atlantoaxial instability. I have no hesitation to say that we have demolished the surgery of syringoperitoneal and syringosubarachnoid shunt, and whoever will do will certainly refer to my articles on the subject where we have said that they are negative operations. Idiopathic syrinx, nobody in the world knew what to do. Decompression and shunts were the only treatment. We introduced the concept that this is not primary, this is secondary, and decompressions are not necessary, stabilization is necessary, and you will see the magic in syrinx, and more importantly, magic with the patient. Long-standing musculoskeletal issues in basilar invagination, like short neck, torticollis, platybasia. You see this short neck, torticollis, platybasia, bifid, clipal file abnormalities are not primary events. They are not congenital abnormalities. They are not embryological dysgenesis. They are due to one problem, and that problem is atlantoaxial instability. You stabilize atlantoaxial joint, and you see the magic. You see this beautiful smile. You see this long neck. There is no need to do any osteotomy in torticollis. Even if there is no smile in this child, there is beautiful neck and beautiful hands and legs. Not only this child has got a new life, the whole family has got a new life. And believe me, understanding the fact that atlantoaxial instability is primary and this is secondary, and this is protective, and this is naturally divine intervention, has great meaning to the understanding of this subject. Another beautiful thing I want to show you, beautiful, and you please see this. This patient of kyphoscoliosis, the whole world will go and introduce screws on multiple levels, and big, huge rod were measuring more than 1 kilometer in length. But many situations, atlantoaxial instability is the primary cause. Chiari malformation, syringomyelia. You treat atlantoaxial instability. You see the magic in the patient. He will start breathing properly. He will start talking properly. He will start jumping properly, and he will have a beautiful straight spine. Even if it is not completely straight, he will be completely relieved of his pain. This boy has never slept supine in his life. In the immediate postoperative period, he will sleep supine and he will be relieved of all his symptoms. Kyphoscoliosis, we must not neglect craniovertebral junction. This is another article on the same subject, that dorsal kyphoscoliosis, atlantoaxial, instability can be the cause. Syringomyelia, when it is present, no question. Chiari, when it is present with kyphoscoliosis, no question. But even when they are not present, these bone fusions will indicate atlantoaxial instability. Assimilation of atlas will indicate atlantoaxial instability. You stabilize the joint and see the magic. The question is, do you have the potential of doing this difficult operation? If you do not have, you have to learn. I know many of the people who are watching are young, enthusiastic neurosurgeons, and I wish they get my message. They don't see ego and arrogance in my statement. They see the potential of revolution in these statements. So these kind of kyphoscoliosis, do not jump with multiple screws and multiple rods. You do atlantoaxial fixation, and this patient, there is a potential of complete cure. You can give beautiful smiles to this patient. You can make a king out of these children if you know how to do atlantoaxial fixation. Also, you know, sometimes central or axial atlantoaxial instability, patient comes with myelopathy. There is no other symptom, no other issue. There is no compression. There is no evidence of any compression, but you see there is bifid here. You see there is syringomyelia here. These are indicators there is central instability. These are indicators of atlantoaxial instability. You stabilize and you see the magic. You stabilize atlantoaxial and subaxial spine in selected cases, and you have a potential. You see this hand was not going up, and this is in the immediate postoperative period, the hand has gone up. You see the shoulder drooping down. In the immediate postoperative period, you see the shoulders returning back to normal. So now I'm saying for sure, I'm saying definitely, I'm giving you a revolution that foramen magnum decompression can certainly become a historical operation. In my understanding, it has already become historical for last 15 years. Now I go to similar concept I used for subaxial spine. And I want Samay, you please try to understand what I'm saying. And I'm going to present to you a beautiful revolution in subaxial spinal understanding. We know about anterior approaches to cervical spines, spondylosis. We all know. And I have done such cases on multiple occasions, multi-level decompression and fixation. Many a time I used to do decompression without stabilization. The whole world is doing. We introduced this beautiful tricortical screw fixation. So in short, I was doing a lot of anterior surgery once upon a time, not now. So you will ask me what I do now, and that I want to show you. If you read the literature on degenerative spine, the whole spine concentrates on the disc. The whole spine says that there is age-related reduction in the disc space and disc herniation due to age-related disc degeneration. I am saying that disc can never go wrong. I said earlier that the whole spinal muscles are focused on the facets. When the muscles become weak, there is a facetal instability. Nothing happens to the disc. And I want to elaborate on this subject. Majority of my understanding of subaxial spine has come from craniovertebral junction. And we wrote this article 11 years ago about my experience with degeneration of craniovertebral junction. Believe me, my dear friends, degeneration of atlantoaxial joint has never been discussed in the literature. Believe me, my dear friends, degeneration of the atlantoaxial joint is the most common form of degeneration of the spine. And we must try to understand this. When there is degeneration of the atlantoaxial joint, most mobile joint, it is atlantoaxial instability and vertical spinal instability, vertical. So reduction in the joint space, you see reduction in the joint space, buckling of the posterior longitudinal ligament, osteophyte formation, are not primary events. They are secondary events related to instability of the atlantoaxial joint, related to vertical spinal instability. So these are secondary events. These are not the problem. They are the solution. Do not ever try to remove these osteophytes and do not ever try to remove this ligament. The issue is atlantoaxial instability and the treatment is stabilization. Ossification in the apical ligament, osteophyte formation. These are not primary events. Do not try to remove this by decompression. Decompression is not the treatment. Stabilization is the treatment. And I have no hesitation to say that any decompression is a negative form of treatment. Retroodontoid pseudotumor formation. I have to tell you, my dear friends, I introduced this concept that retroodontoid pseudotumor is a secondary event to atlantoaxial instability, even when it is not demonstrated on dynamic images. Retroodontoid pseudotumor is like an osteophyte. There is no need to do decompression or removal of this osteophyte, which is secondary phenomenon. It is when it is secondary to atlantoaxial instability, you stabilize and it will disappear. So a retroodontoid mass is an evidence of craniovertebral junction instability. Do not remove this. You stabilize and you see the magic. You see the magic, absolute magic. And this, we introduced this concept that retroodontoid, there is no need for any kind of decompression, whether it is with microscope, whether it is with endoscope. What you need is atlantoaxial stabilization, and you see the magic. Retroodontoid cyst. If you read the articles in the literature, many people will come with endoscope or with microscope, with anterior approach, with lateral approach, and with various kinds of approach to remove this pseudocyst. We are saying, and I have no hesitation to say, that this is not a primary event. It is secondary to atlantoaxial instability. You stabilize and the disc disappears. Even sometimes it can disappear in the immediate postoperative period. More importantly, it is not necessary. In my estimation, it is a negative operation to remove this cyst. This is another cyst with clear evidence of instability. You remove this cyst, it is a negative operation. This is a cushion. This is a bag. It protects the cord inflection and extension. Like Chiari malformation from behind, this is a cushion from front. You do fixation, it disappears. Do not remove this cushion. It will be absolutely negative for the patient. So we have several patients where we have done only fixation. Even this, there is no instability on dynamic imaging. You do fixation, it disappears. Another beautiful thing, you see in os odontoideum, there is a cushion here. And this cushion goes inside the bone. In dynamic images, you see there is a defect in the bone. There is a cushion and there is a defect. And this cushion is a secondary natural protective cushion. You do fixation and this cushion disappears. You see this retroodontoid and pseudotumor in degenerative spine. There is a bone destruction here. There is a cushion. You do this fixation and this cushion disappears. So I discussed recently, and I wish you can read this article of mine where we have said that retroodontoid and retro C2 body cushions are beautiful, beautiful, divine cushions. They need to be understood, they need to be retained, and they need to be protected. Rheumatoid arthritis. Believe me, my friends, This pannus was considered to be a pathological event by the whole world, and transoral surgery developed to remove this pannus. So pannus was removed everywhere in the world till some drugs came into picture, and this pannus is no longer a very serious issue. You see, there is a possibility of immediate postoperative regression of this pannus after fixation. And this was published in Journal of Neurosurgery. I wish you can read this article. So we introduced this concept of facetal distraction and reduction of dislocation. This atlantoaxial joint jamming facetal distraction we introduced several years ago. Many people in the world are using this distraction. Now I go to the facets of subaxial spine. You see this bone. This is the most beautiful facet, the strongest bone of the whole vertebra. The body is very flimsy and thin. Pedicle is not so strong. Facets are the strongest. They are the weight-bearing issues of the body. The whole muscles from the spinous process, from everywhere, are dedicated or focused on the facets, which is the fulcrum of all movements. Facetal instability, like C1, C2 instability. No one in the world has really understood facetal instability. No one in the world. Facetal instability is the primary issue. Instability, vertical spinal instability is the primary issue. Disc space reduction is not primary. Multi-level disc bulges are due to vertical spinal instability. Osteophyte formation is not primary. The whole world wants to remove the osteophytes. The whole world wants to decompress. I am saying that the whole issue is instability. These are all secondary, these are all protective, and they will disappear after stabilization. This concept I am going to present to you. So vertical facetal instability is the nodal point of genesis of spinal spondylotic disease. So I will go from my historical perspective. I want to present what I used to do in 2010. So this article I wrote in 2010, where we said that the facetal listhesis or facetal space reduction is the issue. You introduce a spacer in the facet, and this bulge will disappear in the immediate postoperative period. This ligamentum flavum buckling will disappear in the immediate postoperative period, and there is no need for decompression. So this is what we introduced in 2010. So you see there is multi-level disc bulges, multi-level ligamentum flavum bulges. These are not primary events. They are secondary to vertical spinal instability. Don't go on removing all these segments. Don't go on removing all these segments. You have to stabilize. You have to stabilize. I stabilized in 2010, 11 years ago, using facetal distraction spacers, and they created magic. They created absolute magic. They introduced a new disc in the picture. They completely removed the osteophyte. They completely removed the ligamentum flavum, and most importantly, magically improved the clinical condition of the patient. So you can use multi-level facetal distractors for multi-segmental disease. So what we said, for the first time in spinal degeneration, that compression is not the issue. Instability is the issue, and arthrodesis or stabilization is the treatment. Any form of decompression is a negative form of treatment. So we have got multiple cases like this where we have done facetal distraction and arthrodesis, and you see there is a new disc. You see the whole cord is completely decompressed, and you see the magical outcome of the patient. Unfortunately, my patients are talking in Indian language, and I cannot make them talk in any other language, so I cannot present you patient. So we have got several patients where I used to do. I'm not using it now. You see facetal distraction and arthrodesis and magical clinical outcome in the radiology. So there is multiple patients where we have achieved arthrodesis and there is no decompression. What I want to give you this message, a revolution, that compression is not the problem and decompression is not the treatment, stabilization is the treatment. So you see multiple patients like this where we have treated, you see the whole structure has been completely arthrodesis. Basically, it is vertical spinal instability, which is the problem, and stabilization. You see new disc at each level and no compression, no anterior, no posterior. This is the treatment. So this intrafacetal, intra-articular, it was a concept. It was a technique, all right, but a concept which is completely, you know, the whole world was saying disc space reduction, disc water content reduction, disc space degeneration are the issue. The whole world is still talking about it. I am saying that disc issue or disc space reduction, osteophytes are not primary. They are secondary to one issue, which is your muscle weakness. You have not taken care of your body. Disuse, abuse, misuse, injury to your muscles lead to weakness of your muscles and vertical spinal instability. So we introduced this article in 2010 with a cover page illustration in Journal of Neurosurgery. I wish you read it. I wish you try to understand it. And I wish you use it. So this is a new hypothesis of spinal degeneration. So these are my spacers, and these are very heavily patented in various formats.
Excuse me, Atul?
Yeah.
We, with all due respect, we have 5 more minutes, okay? 'Cause a lot of people want to
No, John, I will need at least 20 more minutes. And
okay.
I want Samay to, because I'm presenting an absolute revolution, John, 20 more minutes, I'm not going to stop. Okay, did you hear that? Samay, did you hear that?
The king has spoken.
The king has spoken and you listen to the king.
Okay.
Okay.
Go ahead.
Okay, I will be a little faster, John, with respect to your version. Okay. Now you see this immediate postoperative disc herniation. There is a disc herniation. The whole world will come and remove this disc. Is there any question in anybody's mind? But there is a potential of immediate postoperative regression of this disc by facital distraction surgery. I don't want to go in detail. The same concept we introduced for lumbar spine, introducing of intra-articular facetal spacers as a treatment for lumbar canal stenosis. And we published this in Journal of Neurosurgery. The concept is same, vertical spinal instability, vertical or telescoping of the spine, not compression. Decompression is not the treatment. So decompression or the compressed or deformed neural structure is the basis of the treatment for spinal degeneration. In the year 2013, we said that only fixation for cervical spondylosis is necessary. No need for even distraction. And in the year 2020, I presented my series with 215 cases where we did only fixation, no decompression for degenerative spine. You see here, there is the whole world will come to do 1 level or 2 level ACDFs, and you all agree that ACDF is the treatment, decompression is the treatment. I do only fixation, and I am saying this will reduce in 6 months. You see these osteophytes have disappeared spontaneously. More importantly, you will see a magic in the patient. Multi-level degeneration. Don't do any kind of laminoplasty. Don't do any kind of corpectomy. Don't remove this osteophyte. You stabilize. You achieve arthrodesis. And you see the whole thing will neutralize and normalize. There is no compression. This is after 1 year. More importantly, is immediate postoperative, this patient will remarkably, and mark my word, remarkably, mark my word, magically, he will improve in, you see this multiple, what you will do? You will do either from front or from behind. Decompression. I am saying decompression is not the issue. The issue is instability. You stabilize by this transarticular fixation, and you see the magic that you have never seen in spine surgery. So this is a new revolution in degenerative spinal surgery. Instability is the cause and stabilization is the treatment. It is not neural deformation or compression, but instability is the cause of symptoms in degenerative spine. More important is you have to understand which segments are unstable and which segments need to be stabilized. And this is not an easy issue. On the basis of clinical parameters, on the basis of radiological parameters, you have to identify. You see, this is 2-level, but I have done 4-level stabilization. And you see the whole system has normalized. Which segments have to be stabilized is a very important issue. Multi-level, do not do any kind of decompression. Only stabilization is the treatment. And I have got many 100 patients now. And I have, you see, you do fixation. And suppose it does not work, you can come from front and do decompression. But I am saying I have never required a second operation to do decompression. So these are multi-level issues and multi-level instability. Stabilization is the treatment. Decompression does not form the treatment. Another magical, Samay, I hope you are, don't talk of time with me, okay? John, please, just enjoy this magic. In subaxial, in spondylotic disease,
Okay.
there is also atlantoaxial instability, which is very commonly and frequently associated. You see, this is multi-level degeneration. There is central or axial, atlantoaxial instability. There is no compression, but there is instability. You have to stabilize atlantoaxial joint and subaxial spine. When the patient presents with severe myelopathy, atlantoaxial instability is almost always present. Even if there is no facetal malalignment, you have to stabilize atlantoaxial joint if you want to see the magic. If you do not do atlantoaxial fixation, the patient may not improve to that extent. So we introduce an alternative method of fixation, which you will like to read from my paper, where we have done. You see this, there is no compression at this level, but I have done C2-3 fixation also. And you see this patient who was on a wheelchair is now walking beautifully. More importantly, I am saying, and that is the concept, that decompression is not the treatment. Decompression is a negative treatment. Stabilization is the treatment. And I have got multiple patients with this kind of issues. And I have got in the audience multiple followers of mine who are doing this kind of treatment. Don't think that this is an abstract form of treatment. In the audience, I know that there are many people who are doing for this kind of compression, no decompression. You see, there is no bone removal. There is only stabilization. And I can tell you magic. Same thing for lumbar canal stenosis. You see, this is in neurosurgical focus, analyzing the role of stabilization and futility of decompression. This is not it is in publication. So for this kind of lumbar canal stenosis, you do not do any decompression, you stabilize and you see the absolute magic. Whether you do with endoscope, whether you use with microscope, those are secondary issues. Those are technological issues or technical issues. This is an revolution in the philosophical understanding that lumbar canal stenosis needs only stabilization and not decompression. Stenosis, this word is wrong. We should not, when there is stenosis, it means you have to do decompression. It is not stenosis. We like to call it multi-segmental instability, and multi-segmental stabilization is the treatment. Is it necessary to remove the osteophytes in degenerative spine? The whole world is removing the osteophytes, and the entire surgery is based on removal of osteophytes. I'm saying, no, don't remove the osteophytes. This is my article you will like to remove. Read. These are osteophytes. You stabilize them, osteophytes will disappear spontaneously. And I have got multiple patients, like when I have done stabilization, the osteophytes have disappeared spontaneously. Is the term degenerative spinal canal stenosis is a misnomer? I'm saying absolutely yes. This kind of kyphosis or scoliosis or degenerative deformities are not primary. They are due to multisegmental instability, and multisegmental stabilization is the treatment. You please read this article of mine to go into details of how I do and what I do. Most important, I do not do any decompression. Another beautiful thing about herniated disc, I do not want to talk in 1 minute about this, but herniated disc is secondary to instability or causes instability. That is why collars are good and belts are good. You stabilize and the disc will disappear. Don't remove this from front. Don't remove it with endoscope. Don't remove it with microscope. You stabilize this segment and it will disappear spontaneously. You read this article for greater details. Similarly, for lumbar radiculopathy, you do not remove this disc. You identify the unstable spine. You see there is water in the facital articulation. You stabilize and the disc will disappear after 6 months or 8 months, but the patient will instantly improve in the symptoms. And I'm absolutely convinced that this is, of course, quite many people will suddenly jump on me saying that, no, we don't agree. We will not like to do this, and this is not good, and this is not correct. But try to see, because this is the revolution. If you do not like it today, you will like it tomorrow. Believe me, I am telling you. Ossification of OPLL. This is another thing in spine surgery. Many of you know OPLL are the dangerous issues in spine surgery. Decompression is the only treatment which has been discussed. I described for the first time oblique corpectomy for these issues. And this is but now I'm saying that atlantoaxial instability and subaxial instability is the cause of OPLL, and stabilization is the treatment. OPLL, do not do decompression from front. Do not do any laminoplasty. You stabilize with very easy technique, this Camillus technique, and you see the magic. Only fixation for OPLL. This was the article I published about 10 years ago. And more recently, I published my experience with 52 cases. You please read this article to see that there is no need to remove this. There is, even when there is no demonstrable instability on dynamic images, atlantoaxial and subaxial fixation will introduce magic to your patient that you have never realized with OPLL. And I also say, if you have a doubt that this may not succeed, you have already stabilized, you can come and do decompression. I am telling you, I have never needed this second operation of decompression in OPLLs, where I have done atlantoaxial and subaxial stabilization. Can it revolutionize cervical myelopathy treatment of OPLL? I'm saying absolutely yes. It will revolutionize the treatment of of OPLL. This Camillus technique is a very unused or misused or underused surgical technique. Such a wonderful technique. I have recently published my experience in Journal of Clinical Neuroscience. I sometimes introduce 2 screws, sometimes 3 screws. This is a wonderful, these are 3 screws you can introduce, and this is a solid fixation. Facets are the strongest bones, like for atlantoaxial joint. There is no bone as strong as the facet. This fixation is the strongest. The revolution is, can decompressive laminectomy for degenerative spondylotic lumbar and cervical stenosis become historical? Absolutely. Is instability the nodal point of pathogenesis of cervical degeneration, lumbar degeneration, and OPLL? Absolutely. So now I'm giving you another thing. Like I demolished transoral surgery, like I demolished foramen magnum decompression. Similarly, I want to demolish anterior cervical spinal surgery. All this decompression from front and decompressions from back, all this endoscopic decompression and microscopic decompression, from only decompression to only fixation can be the treatment. So can it revolutionize? Yes. So my final sentence is, compression is never primary. I'm not talking of tumors and all those things. Compression is never primary. Decompression is never the treatment. Thank you very much, my dear friends. Sorry for taking more time, but I know my dear audience will have enjoyed this beautiful new revolution in spine surgery. And this is not an ordinary revolution. This is an absolute revolution, my dear Samay. And I want you to give me a good smile. That smile has not come.
Thank you, Doctor.
Thank you, thank you.
Thank you, Sir, for this excellent presentation. You have raised a lot of questions in our minds and in chat too. But I'd like to ask you about this case that sent by one of our colleagues asking about what's your opinion. Is it clear?
My opinion is absolutely clear in this case, absolutely clear. Do not do any laminectomy. Do not do any corpectomy. Do not do anterior surgery. You do multi-level cannulase technique from C2 to C6-7. You do a quick operation. This operation, posterior operation, I do in 15 minutes. You do not do any corpectomy, no laminectomy, no laminoplasty, and you see the magic. And you have to, when you do this operation, you tell me, yes, doctor, I have seen this magic and I thank you. You must tell me this. Okay?
I'd like to put some history about this patient. He is female patient, 6 years old, RTA, quadriplegic, paraplegic, C6 fissure fracture, and C7 fracture. You have the same opinion, or you will change it?
No, same opinion. I can see some C3-4 fusion here. I can see some problem in the C6-5-6 disc also. But I think if this patient has myelopathy symptoms, you must do posterior multi-segmental stabilization.
Okay, thank you, Sir. And now, is there any question from panelists?
I am Dr. Salek from Bangladesh. I just want to know about the screw sizes in cervical spine and in the lumbar spine.
Yeah. Are you first, Dr. Salek, you tell me first. Do you think it is a magic? Say loudly, yes.
Yes, I'm enjoying this surgery in the spondylosis, then OPLL. Excellent. I'm doing it.
So you agree with my concept? You agree with my philosophy? Yes or no?
Yes, of course.
Thank
but
you.
it will take us some time to come to a level.
Okay, now the screws about cervical spine, I use 14 millimeter or sometimes 12 millimeter. For lumbar spine, I use 18 millimeters, sometimes 20 millimeters. And 2.7 to 2.8 millimeter thickness, not very thick, like not 3.5 or 3.6. My screws are relatively thinner. They are 2.7 or 2.8 millimeter thickness, 18 millimeter in length in lumbar spine, and 12 to 14 millimeter in cervical spine.
Okay, thank you, sir.
Excuse me. Thank you, Dr. Atul, for your this impressive presentation, your expertise, and the impressive number of operation in cervical lumbar or craniocervical junction speak for themselves. And personally, I have no doubts about this indication. And I become one of your disciples.
Thank you. Thank you. Like John has become my disciple.
Thank
John.
you.
Well, I just request the king that I be beheaded and not shot.
Okay, John. Thank you very much, everybody.
Can I speak, Dr. Atul?